ideas about who's the number one host.
It surely does. So I believe we're going to start off the meeting today with some announcements of some changes of our organization. And Sivan, will you please go ahead with that? You're on mute, Sivan.
Year 2, 3 of COVID Zoom life, and I still talk to nobody. So thank you, Holly, and welcome everybody to our May monthly member meeting. Thank you so much for coming. So yeah, we're Medicare for All, Connecticut. We're a grassroots volunteer-run organization advocating for Medicare for All on the local, state, and national level. We believe in people over profits, that healthcare is a human right, and that your health should never be traded on the stock market or in the hands of anyone but you and your chosen medical professional. We've written statewide legislation, passed town resolutions, as Holly mentioned, with the help of Alder Brackeen, as well as others who are on the call, and endorsed candidates who support our vision for a universal single payer system in which transparency, public accountability, and a more equitable approach to healthcare is possible. If you too believe the same, please join our movement by subscribing to our newsletter, following us on social media, joining our working groups, and donating to our cause. You can check out our website for a ton of articles and resources on single payer, any upcoming events that we have, actions you can take now, there's a ton of them, and other ways you can get involved. And so I will put into the chat our website, our social media information, our donation links, and the like. So that's all there. We also had our first official fundraiser over the weekend with merch. That was very exciting. So please do check out our merch selection now and please contribute at a donation level to receive your free gift. So I'll do a little Vanna White, Bob's Beauties. So we have an amazing tote bag that I already get compliments on. Oh wait, I'm gonna have to unblur my screen so everybody can see it. And that is selling at the $37 mark. That includes shipping. And we've also got this lovely mug, as you can see, very fancy. And we've got buttons and bumper stickers. So please, please, please go ahead now. Let me put that link in the chat again. Sorry. And all of that all those donations go back into our organization so that we can print out our flyers, have materials ready for canvassing, phone banking, things like that. So yeah, and if you buy all four for $65, you can buy those for $65, and that includes all shipping and handling and all that jazz. So very exciting. So there's been a ton of activity going on lately regarding healthcare justice, as we all know. Abortion access, which is healthcare, is about to be stripped away from women and people who can become pregnant. This is absolutely repugnant to us as an organization whose sole mission is to expand access to healthcare for all. We'll not rehash any of the multiple conversations surrounding this topic now. However, we will start a new conversation, one that I've noticed is not going on now, that Medicare for All is literally the only way we can guarantee abortion access for all, because even under Roe v. Wade or codifying Roe v. Wade, women still need to have insurance in order to afford the procedure. Clinics such as Planned Parenthood or other smaller organizations depend solely on fundraising to fund their organizations, making their services available to those coming from out of state or who need financial assistance. However, only under Medicare for All would the issue of healthcare access for all be addressed and ensure anyone who needs and wants an abortion can receive one by their medical professional of choice. That being said, we at Medicare for All Connecticut work tirelessly to bring healthcare access to all, not just women, but to all marginalized communities who are currently under threat by this egregious possible Supreme Court ruling. As our guest speaker will discuss shortly, we have worked this session and previously on fighting for immigrants, the disabled community, women's issues, and more. However, membership activation has waned in recent months, completely understandably due to burnout. And so we're actually asking everyone now to step up and revitalize your passion for single payer care. In light of this request, we're changing our committee structure to now be just one monthly meeting open to all, in which we ask you all to join us in this working group to address our communications and outreach, education and research, and fundraising plans. Electoral and legislative will remain a separate committee due to the delicate nature of its content. We'll soon be sending out meeting invites for the third Wednesdays of each month to meet in this new working group where we can all come together and forge a new pathway. So please, please, please type your name or that you are interested in joining in the chat. And we'll be sure to include you on the calendar invite. So please go ahead and do that. That also being said, there is a ton of Medicare for All stuff happening right now. This Thursday, in 2 days from now, will be a historic day for Medicare for All. After many months of leaving us hanging, Senator Bernie Sanders will be reintroducing Medicare for All into the Senate. The historic part of that legislation will be receiving its second hearing ever. Earlier in the year, it received a hearing in the House of Representatives. And this Thursday, it'll be receiving a hearing from the Senate Budget Committee. This provides an excellent opportunity for us to harness the attention around the hearings and channel it into organizing for Medicare for All and growing our group. We are in coalition with Medicare for All everywhere, so not just Medicare for All Connecticut, and they are helping to organize both in-person and virtual actions, and you can RSVP for either of them here. So this is for Thursday's Senate hearings. Please go ahead and sign up for either of those now. We're proudly co-organizing this event with Whole Washington, Maryland Progressive Healthcare Coalition, Our Revolution Maryland, and Progressive Maryland, and I believe the list is growing as we speak. Then our good friends at T1 International, the organization fighting for diabetes medication access, is holding a virtual conversation called The Deadly Costs of Diabetes, Inspiring Advocacy and Legislative Change, which will center on the root cause of barriers to affordable diabetes treatment and how people can come together to inspire change across medical and legislative fields. At the table, we'll be practicing physicians, state representatives, students, faculty, and activists who share an interest in widening conversation and fostering solutions for various aspects of diabetes care. The session will take place this Thursday, May 12th from 12 to 1:30. And I believe it's being hosted at Yale, but it's also going to be virtual. So here is the information for the T1 meeting. T1 International. And we will also send all of these links out in our follow-up meeting. Give me one. Yeah, it's at the Schwartzman Center. That's the link for that. Next, One Payer States is also hosting a conference, and that will be held, you can attend in person, or there's also online registration for free. Speakers for that will include Mark Dudzik, T.R. Reed, Michael Lighty, good friend, Betty Valencia, Senator Jean Nicholson, Warren George, Chuck Pinocchio, who's actually on the call, and you can, if you are able to join in person or virtually, that's this One Payer States right there. If any of the links aren't working, let me know. And two more things. There's a ton of stuff going on, people. So hopefully everybody can be involved. Husky for Immigrants, excellent news. This year we were able to work in coalition and pass legislation expanding healthcare coverage to undocumented children up to the age of 13. So when you become a bar mitzvah, you're out of luck, but for now, children thankfully can be covered. Our victory this year is a testament to the power that our communities have when we speak up. The fact that we won this victory during a short session year shows that our legislators know that expanding Husky health to kids 12 years and under was the morally and fiscally right thing to do. We look forward to working together in future sessions to ensure our immigrant community can access the healthcare they need. Healthcare is obviously a human right, and no one should be denied healthcare and a chance of survival because of their immigration status, regardless of their age. And so here is a link here that you can send a letter to the legislation, letting them know that you feel this way. Here is that link. Great. And finally, I'm also on the steering committee for the DSA National Medicare for All campaign. And this, I think it's next Thursday, we are going to have an update to our 2022 Medicare for All campaign as we discuss the strategies and tactics for and threats to passing Medicare for All and our plan for getting 20,000 pledges. We'll connect with Medicare for All organizers such as myself, share strategies and ideas for how to organize in our communities. Politicians won't pass Medicare for All on their own. We need a mass movement of the organized working class to force their hand. So please join the campaign and fight for universal health care. So that is here at this link as well. So you have myriad opportunities to come work with us. We cannot wait to work with you and other ways throughout the country to get involved. This is really an amazing time, a difficult time for everybody. I know me as a feminist, it's been a really tough week for me, but being with my friends and colleagues here, Holly and Rana and all my other friends who are here, I couldn't have done this without you guys. So let's just keep trucking, you know. Democracy dies in darkness, so let's show them the light. Thank you.
Siobhan, I have to tell you, and I've told this to many other people, but because of your organization skills and how you do things and how you keep everything set and ready to go, that is why we are where we are today, Medicare for All Connecticut. And I cannot believe how successful we are. And that is in large part because of you, your enthusiasm, and the skills that you have to keep things organized and to move things forward. And gratitude and friendship and solidarity is something that I will always offer to you. But I don't know if you realize how much you mean to so many organizations, especially to this organization. You are basically the heart and soul here. You know, you are the cog that moves the whole entire machine. So thank you. And whatever you need to try to stop this burnout that we're all experiencing, we're here for you. So as you guys can see, of all of the different, I'm sorry, go ahead, Siobhan.
Well, I was going to say thank you, but I also forgot we have a canvas this weekend. So there's another thing for us to do, which is our Hamden Town Resolution Canvas. And so I'm dropping that in the chat. That's going to be from 1 to 3 p.m. Please, please, please join us. Yes, thank you, Pete. And thank you, Holly. That was really nice. Thank you.
Well, it's true. So I don't want to make anyone too further later tonight. Not that those words made sense, but I would really like to introduce to everyone our amazing speaker tonight. I have known Sheldon for a while because of his advocacy and because of his personality and how wonderful he goes hard at legislators and asks the tough questions. But I will certainly read you about him and what he has accomplished. Sheldon is a graduate of the UConn School of Engineering and the University of Pennsylvania Law School. He came to Disability Rights CT with 33 years of experience working for legal services programs in Pennsylvania and Connecticut. Throughout his career in legal services, Sheldon developed expertise in representing individuals seeking eligibility or specific services under the Medicaid program. Becoming knowledgeable about the state and federal laws governing this complex program, he also led or co-led counsel in several federal court class actions against the Connecticut Department of Social Services under the Medicaid program, resulting in statewide court judgments or settlements benefiting tens of thousands of low-income individuals, including many people with severe disabilities. Sheldon also developed expertise in using multi-forum strategies to advance clients' access to health care. He co-led a campaign over many years to replace risk-based insurers running the Medicaid program with non-risk administrative service organizations lacking any financial incentive to deny needed health care, coupled with the broad use of patient-centered medical homes, paid extra for coordinating healthcare in a way promised but rarely provided under the old insurance company-run system. The changeover implemented in 2012 has been to the benefit of hundreds of thousands of Medicaid enrollees, excuse me, as the program has grown dramatically, especially since the Medicaid expansion authorized under the Affordable Care Act. So basically, guys, Sheldon is one of the two people responsible for making our Husky program in Connecticut one that is the gold standard that all of the other states look up to. So that being said, Sheldon, please go ahead and present to us. Thank you so much for being here.
Thanks, Sally. Thanks very much. And it's funny because I have talked to single payer, Medicare for all, Physicians for a National Health Program chapters in other states about how they might move away from using insurance companies, risk-based insurance companies in their Medicaid programs. But I've never talked to a group in Connecticut about it. It's interesting. But anyway, that's not what I'm here to talk about today. I'm going to talk about some of the legislative battles we've had. And I mean, I've worked with Holly and Savon on a lot of this stuff, but you know, the rest of you don't know it. I did want to talk about the overall setting for this, and that the overall setting, of course, is that there's healthcare is very expensive, because you didn't know that. And the rate of inflation in healthcare is high, although frankly, given what we're seeing with inflation in general, I'm not sure that healthcare will be higher than, you know, than general inflation this particular year. But over the last few years, it's been higher, not in Medicaid, where we have it under control because we don't have insurance companies running it, but in general, the rate of inflation has been high. So people felt the need to deal with that. And both consumers and employers are feeling real pressure from the annual increases for premiums, as well as cost sharing. And it's important to recognize that most of the health insurance system we're talking about, not Medicare, not Connecticut Medicaid, most states have insurers, but not Connecticut Medicaid, you know, they use risk-based insurers, and those insurers have to take their 15 or 20% off the top for administrative costs and profits. And although that 15 and 20% figures, those are capped by federal law under the ACA, when you think about it, the more that the total costs go up, the better for them, because they can keep 15 to 20% of 15 to 20% of a large number is better than 15 to 20% of a smaller number. So it does not serve to make them want to keep overall costs down. And by the way, we compare that 15 or 20% with Medicare, which is about a 3% administrative cost, and the Connecticut Medicaid program without risk-based insurers is about 2.8%. So all these insurers have very high administrative costs of profits off the top. Providers spend a lot of money on administrative costs fighting with the insurance companies, both to get prior authorization and where prior authorization has been obtained or otherwise getting paid. The bills just don't get paid. They have got to fight to get the claims paid. So they spend a lot on administrative costs as well. And then lastly, and of course, this is no news to anybody here, but in the absence of a single payer system, there's very little bargaining power where the one payer can demand, for example, the pharma, lower prices and have prices that sort of reflect what the story is in the rest of the world. No, because we've got all this fragmented system, we don't really have that bargaining power. And you all know that Medicare was prohibited from negotiating on drug prices. So we have a really serious cost problem, and politicians want to do something about it. And they don't really have an answer because they're not willing and able to do anything structurally, such as Savon laid out in the beginning. So in the absence of that, they sort of are doing various, attempts, moving deck chairs around, or I would say distorted maneuvers that give the appearance of addressing the cost control issue without really dealing with the ultimate root cause of the problem. Not well advertised is that when the Affordable Care Act was passed, the big parts that everybody knows about is the Medicaid expansion and the exchanges and subsidies for buying insurance on the exchanges, plus some insurance reform, such as the 15 and 20% caps for administrative costs. Most people know about that, but very few people know that another part of the bill was the creation of an office at HHS and the Center for Medicare and Medicaid Services and funding to basically do experiments to try to save money. And they created something called the Center for Medicare and Medicaid Innovation, CMMI, whose job it was to see if we can come up with things, try anything, whatever, see if we can save money. This thing's out of control. What can you do? And that office was created. And I will tell you that the current commissioner of DSS, Deirdre Gifford, worked there, pushing these models. That was her job before she came to Connecticut to run DSS. And not surprisingly, she's rather fond of those models. The general category of what they were looking at was what's called alternative payment methodologies, which is a very broad term and could mean a lot of things. It could mean, for example, a model we have in Connecticut, Medicaid, which is to pay fee for service for all health services, but to pay providers basically a reward if they do well in quality measures. So you're testing for ER usage or rehospitalizations or a variety of things, numbers of screenings. You can do a lot of different things on that, and you can pay for that as a reward in addition to paying fee for service for each healthcare visit. And that's an alternative payment methodology. But that's not generally what came out of the Affordable Care Act and CMMI. Rather, their idea of alternative payment methodologies really means pushing financial risk onto providers. So insurance companies are at risk, right? They get paid, they collect their premiums, and then they try to keep that money, and everything they pay out comes out of their bottom line. They don't want to pay out. They're at financial risk. So the general idea is, hey, maybe we should move that down a level. So instead of the insurance company, or not instead, but in addition to the insurance company being at financial risk, being paid a capitated amount basically for premiums, let's move that down to the provider level and put financial risk on them. And there's a lot of different models within that, but the predominant sort of approach has been something called shared savings, where providers get to keep a cut if they save money on the total cost of care of their patients. So that is something we also have in Medicaid in Connecticut. Unfortunately, advocates opposed it, but it came into being in something called PCMH Plus. But basically, what that model is, yeah, the providers get paid fee for service, primary care providers, but if they save money on the total cost of care, whatever, drugs, everything, add it all up. If they save money, they get to keep half of it. So now the provider, of course, has a financial incentive by definition, that's the point, in keeping total costs down. Is that a good thing? Is it a good thing for your provider to have an interest in keeping the money that goes out the door down because they get to keep half of it? I'll leave that for you to answer that question. But in any event, that's one approach. And another more severe approach is capitation. And that's where the provider doesn't get paid anything fee for service. They get paid a per head fee per patient per month or quarter. And that's it. This is the dollars. And you do what you want. And we hope you'll do a good job. Well, maybe, but more likely we'll try to avoid providing care because it comes out of your pocket. That is to say, if you're a large provider, you contract with, you have to employ a bunch of providers. The fewer appointments you're making, the fewer providers, individual providers you have to employ, and the better off you are financially. So you can see the incentive. So this is all the background. Now, these models haven't been very successful. I mean, they've caused a lot of angst, and to some degree, it seems that they're restricting access to care, but they haven't really saved a lot of money. And Medicare is the program that's done the most experimentation in this through CMMI, and they really have not saved money. So we have that sort of unsuccessful overall approach. Meanwhile, on the provider side, there's been something called consolidation. And we're seeing it big time in Connecticut, where the hospitals are consolidating both the for-profits and nonprofits. And they are getting more powerful, right? Hartford and Yale New Haven together own about half the hospitals in the state. And they actually have some pretty serious bargaining power with the insurers, which is sort of the exact opposite of what I said at the beginning. If you had single payer, you'd have the power to negotiate. I talked with pharma, but it also applies to large hospital systems. So that's the background. We're looking for a shiny new toy. What can we do to save costs? So the shiny new toy is benchmarking. And benchmarking means, well, like almost everything, it's a euphemism. Benchmarking means that we're going to try to control overall costs by collecting data on overall costs, which seems like a good thing, just to, data, what's happening, that seems reasonable. But then to try to force reductions in total outlays on a global basis. With payers, certainly with payers, but maybe reaching down to large providers. That's the idea. And so that brings us to the initiatives of the Office of Health Strategy. The Office of Health Strategy is a very new state agency. You've all heard of DSS, which has been around for decades. Well, actually used to be called something else, but long established agencies, Department of Public Health, Department of Mental Health and Addiction Services, also different names, but they've been around for decades, providing basic services and to some degree innovating and administering programs and services. Well, Office of Health Strategy has only been around for a very few years, but it's very, very ambitious. And so they see an opening to try to grow fast and build an empire by filling in the healthcare reform, healthcare strategy space. And that's exactly what they're doing. So they have, since the beginning of their creation, like 5 years ago, and before, the people who ended up running it, even before that office was created, have been aggressively pushing these payment reform models, specifically capitation, shared savings, and something I didn't mention called downside risk, which is basically the same thing as shared savings, except it comes out of their pocket if their patients are too expensive. They don't just not get half of the savings, they pay money back. So another bad model, in my humble opinion, in terms of pushing risk onto providers. All of these models were already something being pushed by the people who created the Office of Health Strategy. They then have that office and they've been wanting to push those models. But what they came up with in the last year or so is something called the Primary Care Roadmap. And the Primary Care Roadmap is a 20-page detailed document with exhibits and everything. And the basics, it's more than this, but the basics are primary care is broken. Primary care is broken because of the fee-for-service system. We need to move to capitation, and we have to put more money into primary care. So we need to take the dollars that are going to healthcare, put a higher percentage going into primary care. And we here in the Office of Health Strategy, remember I said kind of empire building, we are going to be in charge of all this, and we're going to set the standards for these primary care practices and what they're going to do. And by the way, innovation will come out of this, because when we pay on a capitated basis, magically, these entities will want to provide extra services they're not providing now, but they'll be motivated to provide it because, oh, I never got that part, but they will be, trust me. And the roadmap was set out, and they've been promoting it, but that wasn't enough. They wanted legislative approval and endorsement of it. So there were two bills, SB 15 and HB 5042. SB 15 was about primary care, but the critical part I want to note is that it specifically defined primary care as not including services, primary care services provided by OBGYNs. I'm not asking for a show of hands, but I know there's many women who go to OBGYNs for their primary care. So the bill said that's not primary care. We're defining primary care. It's not counting that. Wait, what do you mean? So if you want to know the reason for that, and they admitted this, the consultants the Office of Health Strategy hired, is if we counted that, we'd already be at the target we want. They have come up with an arbitrary target of 10% of all healthcare expenditures should be for primary care. If we counted the OBGYN primary care, we'd already be at 10%. So we can't do that, because then we have nothing to do. So instead, we're going to exclude that, and we're at about 5.3% if you look at commercial insurance. So that gives us a lot of room to make, cause trouble, expand a lot more spending on primary care. But keep in mind, this is in the context of a proposal called the benchmarking, which is the basic point of 5042, which controls overall cost. So simple math, folks, even those of you who are not good in math, simple math, we're going to lower the total outlays. We're going to dramatically increase spending on primary care as a percentage. Oh, where's that going to come from? It has to come from somewhere. And that is what advocates have been so worried about. Because of not addressing structural problems of costs, and instead moving deck chairs around and these distorted, tortured solutions, the benchmarking is basically going to try to address high costs. But if you look at this model, what it means is that, oh, it might come from behavioral health. It might come from other specialists. It might come from dental care, from home health aides, from whatever. How are you going to make it work? And nobody, all the proponents of this bill and everybody who voted for it didn't want to hear about it. Frankly, they just didn't want to hear that the math doesn't work. And the only argument that was ever made for why it couldn't work is that the Office of Health Strategy and the administration argued that, well, if we spend more on primary care, that'll keep people healthier, so that'll save money overall, which sounds reasonable. I mean, that to me sounds reasonable. But remember CMMI, that office I told you about? They've done experiments with this. And guess what? When they spent money on primary care, more money on primary care, which may have been a good thing, not knocking it, it never saved money overall. It cost more money. So that solution doesn't work. So therefore, the basic math, the third grade math I said before, is that, oh, we're going to lower overall costs, we're going to increase primary care. It's going to come from somewhere. This has been the real worry. And I represent people, I'm at Disability Rights Connecticut. We represent people with severe disabilities. We are very worried about people with all kinds of disabilities getting the shaft here, because they go to different kinds of providers. They consume a lot more healthcare than most people. They go to specialists. And how's that going to work if healthcare costs have to come out of that? The other thing the bill said is that this Office of Health Strategy is now going to be given power to direct and oversee alternative payment models throughout the healthcare system. So that's what we talked about earlier. That's what Office of Health Strategy and its predecessor always pushing. It's what CMMI has been pushing. And where it's been done, it's not been a pretty picture, and it hasn't really saved money either. So we were very worried about that, and advocates also opposed giving that kind of authority over. one thing you should know is that the model for this comes from Massachusetts. Benchmarking is premised upon the supposed success in Massachusetts. And if you look at what they've done in their benchmarking system, they have saved some money overall, it seems, over this time period, or a time period that sort of overlaps with the period of the benchmarking. But it sort of doesn't overlap completely, and it's really unclear whether that is the cause and effect. But even if it has saved money, nobody disputes the following statement. Any money saved in Massachusetts through benchmarking, or at the same time benchmarking was done, we won't say it's cause and effect, has not resulted in any savings for consumers, meaning it hasn't lowered premiums. The whole point of this, the whole marketing of the benchmarking, all the arguments that were made by both the administration and legislators as we voted for this thing, the argument was that, well, we really need to save money for consumers. It wasn't about saving money for insurance companies. It was about saving money for consumers. The model, Massachusetts, has not saved money for consumers after several years. So why are we doing this? Well, a lot of advocacy went down, and the result of this effort is that there were some improvements in the bill. Remember the bill I said about defining primary care, a separate bill defining primary care as not including OBGYNs, that came out. That doesn't mean the document called the Primary Care Roadmap by Office of Health Strategy won't still be followed, and that says we don't count OBGYNs as their primary care. We don't count that as primary care. So we're not out of the woods, but at least that was taken out. Makes the argument a little harder for them, I think. But on 504.2, they've removed any authority for the Office of Health Strategy to be able to direct these alternate payment methodologies. So that's a good thing. The only thing left is they can monitor those methodologies as developed, but they don't have authority. If they try to impose it, we can say, hey, the legislature rejected that. That was in your original bill, it's gone. Then with regard to the basic benchmarks and it doesn't say 10%, but everybody knows what's intended is 10%. The legislation says that they should go to set a primary care target as a percentage of overall spending. That's in there, unfortunately, but there are some improvements. For example, Office of Health Strategy has to develop and present a report on a plan for monitoring any unintended adverse consequences resulting from the adoption of cost growth benchmarks and primary care spending targets, and the results of any findings from the implementation of such plan. So that's an opportunity for advocacy to say, yeah, we want to see that plan. We want to see it early, and it's got to have these things, and we want to see how you're going to implement it. That's not as good as it could be if it was subject to approval by legislative committees or the legislature, which we asked for and did not get, but at least it's something. And in the future, if they want to raise the benchmarks over a certain amount, then they would have to come back to the insurance committee for approval. It's not much, it's actually very little, but it's in these little crumbs we got. Overall, it's a really, really troubling bill. And one of the reasons that they were able to get it through is that at the end, they tacked on certificate of need legislation, which was a step in the right direction to have the same Office of Health Strategy also does the hospital certificate of need reviews, and that's whether to close down, for example, maternity ward or whatever. And so that authority, there was a little bit of beefed up authority to OHS, which has already done a really, in my opinion, poor job of running the CON system. But that was the sort of one of the deals that was put in. I think that was done intentionally in order to get more legislators to sign on to what is otherwise a really, really troubling bill. So that's what passed. And then there's other things that might have addressed costs in a meaningful way, which didn't pass. So some of you, I think Ellen Andrews spoke to you guys about 416, right, which was a bill related to hospital consolidation, which was designed to try to sort of push back at the really big hospitals who have really big market share power now, to try to give basically the other side, which in this case is the insurance industry, a little more power when negotiating with them. And sadly, that bill to prohibit certain anti-competitive contract provisions died. SB 13, which would have brought some transparency in drug pricing, some controls on inflation in drug expenses, that died. So there's really very little, and I know that the administration is touting 504. It didn't come as 504 it went into the big implementer bill, the budget bill, overall massive, what they call aircraft carrier bill. I know that the administration is doing a victory tour saying how we've really got to save money. As I said, in Massachusetts, it didn't save anything for consumers, and that's all the public cares about. It's going to save for me, or the small business is going to save for me. And in Massachusetts, it didn't do that. So I think basically, if I had to be honest about it, I think the legislature has been sold a pig in a poke, but that's what happened. I've been talking for quite a while, prattling on, and I was told that there should be 10 minutes for Q&A. So I guess I should wrap up.
Thank you so much, Sheldon. Does anyone have any questions for Sheldon?
Yeah, this is Will Treen. Can you hear me?
Yep.
Great. Yeah, thanks, Sheldon. It's a little distressing for me to hear that spending more money on primary care does not result in savings, overall healthcare savings for whether it's for consumers or Medicare, et cetera. Is this? I guess my question is, it might take some time for increased expenditures or increased money for primary care to actually result in definable cost savings, because they will be reflected perhaps by the avoidance of deterioration of certain conditions over the long term in chronic diseases, hypertension, diabetes, other very common chronic diseases. It was this experiment, as you phrased it, done over a long enough period of time and controlled well enough to really make that judgment that spending in primary care does not result in cost savings.
So that's a really great question. And I want to preface my answer by saying, I am not in any way dissing increasing spending on primary care. That could be a very good thing to do, regardless of whether it saves money in the long run or not. That is something to be supported. The problem is that in the context of what we're talking about here, it's done as a package deal of lowering overall costs, right? So that's where sort of the issue comes. The studies were done by specifically in Medicare, and I believe that they did have a decent control. I think it was over 3 years. I have to check that. So what you're saying is not obviously, it's not invalid. That it could be that it would take longer. You'd have to run the experiment longer to see where you might actually get the savings. It does, as I said, it makes sense to me. It totally makes sense to me. If you spend more on primary care and you're providing preventative care and you're addressing things early on, it does seem that overall for the system, it's going to be better. It's going to save money. And I know that advocates like me have always believed that. And it's just that this is, I mean, it's not definitive, but this is the organization created to actually run these experiments. And in this particular case, through Medicare, I think it's called the Comprehensive Primary Care Initiative. The extra spending did not do that, but I could look and see exactly the articles that have reviewed it and see how long the experiments ran for.
Yeah. Thank you.
Justin, go ahead.
Yeah, thank you, Sheldon, for a very thought-provoking and informative presentation. I really appreciate it, and it's got me thinking a lot about different models, and particularly in Medicaid. I don't know, it strikes me as kind of sadly funny that these groups are scratching their heads for ways to save costs, but avoiding the idea of taking the profit motive out of health insurance as a profound cost-saving measure, and maybe even taking the profit motive out of hospitals. But my my specific question, and I also wanted to chime in and think that I think, we should really not dismiss the idea that primary care, in particular preventative care, being emphasized. I would still expect to yield a cost savings in the long term, and you're not disagreeing with that. But there's another idea that I'm wondering how much focus it's getting, which is the idea that advanced directives and living wills, if people are encouraged to fill them out and given the resources necessary to fill them out thoughtfully, could produce cost savings in the long run for medical care, because such a large chunk of a person's healthcare expenditures end up being towards the last years or last few years of their life. And some of that ends up being maybe not what they intended to be doing in the last years of their life, and that advanced directives and medical wills can prevent that. Are you aware of what the latest experiences with people or any organizations that have tried to just make these resources available to patients, and whether that results in a savings?
I don't know, but I don't know the answer to the question, but I can tell you there is another problem there. I represent people with disabilities, people with severe disabilities, and there is real worry about folks being sort of moved into that, feeling pressured into that, that it will result in, people who wouldn't otherwise go there and ending up saying, yeah, I don't want that, in part because there aren't the adequate resources, right, for end-of-life care that we should have. And so they don't generally want to see those kinds of things encouraged. And for those of you who remember, during the Affordable Care Act debates, do you remember the death panels, the non-existent death panels?
Right.
So one of the things that the Republicans used, that they trotted out to try to oppose the ACA, was the claim, false, that there are going to be death panels that are going to review whether somebody gets to live or die. And all that was payment to providers for having a visit with a patient to talk about the very thing you're saying.
Right.
That was distorted.
Yeah, I remember that. Yeah.
Yeah. So obviously, that was ridiculous. It almost worked. But I mean, I think that I in my previous job, I did, talk to people and help people do the advanced directives, fill them out. I mean, I think it's really important, but I think that if you start talking about it as a money saver, honestly, I think that's where people are going to get their backs up. Yeah,
I mean, it's a legitimate concern. I think it's it's something that I think a lot of people are glad. You have experience with this. I think a lot of people are glad they did it, or that their family members did it. It's thinking ahead in a way that a lot of people. It's like writing a will. Sometimes it's often, I think, in a person's best interest, and it's empowering themselves, I think, in a way. But I take your point that it needs to be done in a way that's sensitive to concerns about people feeling pressured into making decisions that aren't in their best interest. And again, it's just a thought that occurred to me listening to your talk about these people, about and I've been following the Medicare, the Center for Medicaid and Medicare Innovations efforts to privatize Medicare, that's ongoing with the ACO REACH and the DCE issue, and all of these, which is just going to bring in more profit motive into Medicare. And if they keep the cost the same, that just means less care, because it means more profit going to more private interests. So again, our focus as a public, this group's focus is on providing care and expanding care, less than it is on saving money. And it's almost a happy accident that universal single payer healthcare would be less expensive than the current system. And so we focus on that. I like to focus on that as a win-win, and would wish more people would come on board with that way of looking at things. So it's discouraging me that these efforts are being made, and people bending over backwards and knots to try and keep the profit motive in healthcare and save money. I don't know your thoughts, but those are just some thoughts.
Got a lot of thoughts, but I don't think people are gonna be that interested in my thoughts because they're not I don't have the expertise in that area. Susan Johnson, Representative Johnson has a question.
Thank you, Sheldon, for being so focused on these issues. And sorry I was late, but I had to be at a convention, so for the 29th. Anyway, I really wanted to check in with you on the Connecticut PACE program that the Commissioner of Human Services is going to try and do a state plan with the federal government. And I just wondered if you had any familiarity with that.
Yeah, I have familiarity with it. I think it's a really bad idea. So
yeah, that's what
basically,
I thought too. We agree. But I do want to have. I thought we'd talk about a complex care committee meeting, but I did want to do a little research, and I didn't know if you had more than what was in the proposed bill. And I
haven't seen the final bill, but for everybody, since most people probably don't know what the PACE program is, right?
Right.
The PACE program is a program for all-inclusive care, I think.
Well, yeah, and to combine the payment systems of Medicare and Medicaid, which it blew my mind when I saw that, because it's like, what? I mean, that seemed very strange. It seemed almost like they were trying to move it to some other realm, and I just
the key, I think, in PACE programs to understand is per the discussion. I think you may have not been here my introduction about the different alternative payment methodologies and the move. That CMMI has been pushing these alternative payment methodologies. Specifically, they've been pushing capitation, and PACE program is by definition a capitated program. Right. So what it does is it takes the state Medicaid money, which of course is combined state and federal, and the Medicare money, which is entirely federal, and pays an all-inclusive capitated rate to an entity, which then, of course, like all capitated entities, has a financial incentive to cut corners in order to save money. And that's the part that nobody ever talks about when they come and present and how great PACE programs are. They always leave out the part that it's capitated and that the entity will have a financial stake in denying care. So that is to say the provider entity will have a financial stake in denying care. So I think it's really problematic. I think I think it almost fits into what I was saying at the beginning, which is that because we're not addressing, as sort of like Justin just said, because we're not addressing the real structural issues, the real reasons why healthcare is so expensive, that instead we're doing these distorted things that sort of look like they have the appearance of saving money and may or may not save money, but certainly cause other problems, cause unintended consequences, which may be more harmful than the disease that we're supposedly trying to treat.
Well,
so,
what they do is try to cost shift everything from one place to the next, and it looks to me like it's just another cost shifting mechanism to try and just move things on to well, they can't move it onto the agencies anymore because they've already shifted everything off, and then the agency shifted onto the straight Medicaid program. So I'm not sure how, if you combine Medicaid with Medicare financing, how that would work. But then again, you've got capitated home care services that was capitated in '97. You have capitated hospital services, which was done the DRGs. So you've got all these different programs that are already capitated. So I don't understand what the purpose would be of combining the Medicare and Medicaid payment systems, unless it is to try and also confuse and do a cost shift. I just wonder where that cost shift is going, I guess, was my ultimate thought.
I hope that this will be considered by the Medical Assistance Program Oversight Council and the committee that you're a chair of, the Complex Care Committee, to take a serious look at this, because I think it is a problematic model.
Well, we're gonna bring it up in June. And so I thought I'd raise it here with you since you're here. And see what we could do to find out more about that. And I have another question if we have any time. I don't know, but I won't take your time if you don't have time, and maybe we can talk off. But it is about people with disabilities. It's about the people's personal care attendants, the situation with the no compete agreements, and the $10,000 fine if you make a request for for a hearing in that circumstance. So which would really inhibit the Medicaid beneficiary from doing that request. And I didn't know if you had any experience with that. And if this is takes too long, then that's fine. We can talk offline.
Excuse me, I'm sorry, State Rep Johnson. I have a
Yes.
person who has 2 questions for Sheldon. Would
Yeah.
you mind if we took her questions?
No, not
And
at all.
then if you guys want to hang on after, I don't mind running the meeting for a little while longer.
Right.
But Martha had put her questions in
I'm sorry.
previously. No, that's okay. It's I enjoy listening to the
Oh,
discussions. I
thank you.
learn a lot. Thank you. Martha, please go ahead.
I apologize. I really didn't mean to stop your conversation by any means. I am not sure where my question fits in to the conversation, but I'm interested in hearing because I've known Sheldon for many years, but not recently. And I'm curious to get his reaction to things. I'm covered by traditional Medicare, and people tell me about the great advantages of Medicare Advantage. And I've also heard of, I see your answer, Holly, and I've also heard of DCE. And I misstated in my original question and put perhaps ME, but I think it's DCE that's related but different, involving providers. Is that right? So those are my 2 questions.
Yeah, I can't find your question back in the backup, but I could just
Don't worry about
very
it.
briefly answer that Medicare Advantage is almost always a disadvantage.
Okay,
It is,
thanks.
again, it is taking the very efficient 3% administrative cost, single payer Medicare system, and instead taking some of that money and paying it to a for-profit capitated entity, which takes a huge amount off the top, and then proceeds to restrict the network. That, I mean, there's 2 ways they make money. One is they restrict the network, so you only go to certain providers. Instead of people think they're on Medicare, they can go to any doctor. Wrong, because it's only going to be who contracts with that insurer. And then secondly, they restrict access to care if you have to be prior, or they impose prior authorization. They're free to impose prior auth wherever they want, and then they proceed to deny prior auth. So you really get restricted in it. The reason it's so popular, and it's over, my understanding is approaching 40% penetration. The reason it's so popular is that they have managed to, very clever, really. They've managed to manipulate the system so they get overpaid. They get overpaid per person relative to what the general population is. So they're getting more money coming in, and then they use that money to, and you've all seen the ads, to entice people to sign up by offering crumbs like $1,000 in dental or $1,500 towards hearing aids, or some little crumbs that sound, pretty good. I mean, they're freebies sort of, but it's a deal with the devil, because now you're restricted in your provider network, and now you're gonna, if you get sick, if you don't get sick, it's great, you save money, it's wonderful. But if you end up getting sick and actually needing real health care, now you have a real problem. So really, Medicare Advantage is a really, really troubling development. And the reason it's happened is a combination of very powerful lobbying by the insurance industry, an unwillingness in Washington among some legislators to do anything about it, and then this aggressive advertising campaign by the not just insurers but also brokers who make money. They actually make money by by each referral. So by the way, I'm turning 65, so I'm like totally a victim of all the advertising from both the brokers and the companies, and I really see it, and it's grossly misleading, because I do happen to know something about Medicaid coverage and Medicare coverage and what you get. And one of the things that's most disturbing is the marketing to Medicaid people who already have comprehensive coverage, telling them they have to sign up for the Medicare Advantage plan in order to get things you already have. They're on Medicaid. So it's really problematic. That's Medicare Advantage. And then the other thing, which the letters I forget stands for, I know that probably people on this call know this way better than me, but my understanding is that's a new, basically another capitated Medicare model that is going to be in targeted areas around the country that they propose. And unlike Medicare Advantage, you sort of choose it, and maybe you don't very intelligently choose it because you've been marketed at and there's not a response, but at least it's a choice. Whereas under this proposal, it's going to be basically you're put into it as an experiment. So, but at bottom, both models are the same. They're
That's what I've
pushing,
been really
like we said at the
afraid of.
beginning, pushing financial risk onto an entity in a program which is otherwise very well run, very efficient, single payer, and slowly sort of privatizing it, so it will no longer be the efficient model that we've had, which could be a model for what you all support, which is Medicare for all.
Thank you.
Does that
Joe.
answer your question?
I've been holding the line against like 3 family members who tell me, oh, this is so great. And taking a lot of guff, but thank you. I appreciate it. And if I were here more often, I would have heard what you all know, but I found it elsewhere. Thanks to the teachers union and Ralph Nader and so on. Thank you. Thank you, Sheldon.
Welcome. Maybe I should speak with Representative Johnson, off the record,
Okay,
later
Okay.
to talk about that issue. It's a
Okay.
very specific
Yeah.
issue that it's a real concern, but it's a very specific issue. And
okay.
I'm very much involved in the issues of access to personal care assistance for people with severe disabilities who need those, and that's one of the many problems.
Yeah, it's a
Yeah.
tangle, and I would love to spend some time with you and iron, after looking at this legislation that we passed to get rid of some of it, there's still more to do. And I would like to go through it with you and then propose the legislation to fix the rest of it, because
Okay.
I was really distressed this session that nobody understood